I would like to thank all of you for the opportunity to share my passion and the history of what virtual care has meant in my career and the ability for us to change healthcare. I also want to apologize for my lack of Dutch. I have a Dutch wife who has joined me, but she also does not speak Dutch, so we apologize. But what I hope to do is, if there is one thing I can accomplish, it would be to capture your heart and to take the intelligence and the resources in this room and to increase your focus on what virtual care may be. My journey began 40 years ago. I was a young student doctor at Johns Hopkins in Baltimore. The first patient I had been in the hospital as a 35-year-old man for a year and a half. He remained in the hospital the entire time I was training, and for another year after that. I saw the power of what medicine can do to keep someone alive, to treat complex disease. But I was also told that Jim would never be able to go home. He was being fed intravenously. He had multiple problems, and with the intravenous feeding and the catheter above his heart, he was never to be able to go home. And he didn't, and he died. And we were only paid for taking care of him in sickness. We were not paid or had a budget to take care of him in health. And what virtual care can do is allow us to bring health and care to people where they are. Fast forward 15 years later, I was chief medical officer of a company that was taking care of over 10,000 patients like Jim in their homes, no longer in the hospital. It was said that couldn't be done. So I'll challenge you to think about what we can do differently. And the regulations are different, the laws are different, the culture is different from country to country, even from state to state. And in Mercy, where I practice, from city to city, are different medical practices. But the diseases were not different, and people are not fundamentally different. Our health and care is different, but what people need is the same. But this is the biggest challenge we all face. None of us really like to change. Perhaps in this room it's different. We have people driving change. But change is really difficult, probably most difficult for us physicians. We were taught to do things a certain way by our mentors who taught us that was the only way to do it. But again, I will challenge you and say it can be done differently. Mercy, just to give you a background, is a system of about 40 hospitals, about 4,000 hospital beds, hundreds of clinic sites, 3,000 to 4,000 physicians, and 40+ thousand coworkers. We built a virtual hospital, just one. But the virtual hospital was not meant to be by itself. It was meant to change care in all of our hospitals, with all of our doctors, all of our clinics, and for all the people we could serve. And to do that not just at Mercy, but at other hospitals. We did it at Penn State University, University of North Carolina, a lot of small hospitals, to use our resources and our teams to create the change. Driving the change, there has to be a compelling reason. It is interesting that the Mercy system was founded by the Sisters of Mercy from Dublin, Ireland. They were a very unique group of nuns because at the time, the Roman Catholic Church wanted nuns to stay cloistered in their convents. The Sisters of Mercy refused because they said, if we can go to care to where people need care, instead of waiting them to be put on the steps of the convent, we can help people much more. And yet, their healthcare system evolved to where we waited for people to come to us, even though if you go to people, you can help them much more. And to start, I want to give you one example to get you thinking. The one example I would use is we began an ICU program you'll hear about in a video for the intensive care unit. We would have 6 to 7 intensive care teams working 24 hours a day in the virtual care center to assure that 24 hours a day we could spot problems, we could be very proactive in our care, we could complement what our existing bedside doctors were doing and nurses. But to make sure care could be the same 24 hours a day, and whether you were in a major hospital with 1,000 beds, our biggest teaching hospital, or if you were in a 20-bed hospital, 500 miles away from a big hospital. And here's what happened. We found that we were able to reduce how long people were in the intensive care unit by about 2.5 days, which became about 50 to 60% of the time somebody spends in an intensive care unit. As we grew, that took us to about 50,000 intensive care bed days not used. That's business speaking. It's 50,000 days someone did not have to be in an intensive care bed. And then when we sent them to the floor, we saved an additional 80,000 days. More importantly, there were approximately, in 2018, approaching 1,200 people who were statistically predicted to die that went home. Look around you. In this whole conference, 1,100, 1,200 people, the entire audience, everyone dies or everyone lives. And by keeping them well, by focusing on practicing 24 hours a day, we saved $75 million of cost. But in the old model, that was a $75 million budget or $75 million of revenue because we were paid to do things to people. We weren't paid to get them well, keep them well. And that's what we have to do differently. So I want to show you a video next. And the video is for one of our patients who was in our hospital over 20 times in 2 years before we changed his care. He had terrible emphysema. His lungs were at end stage. And he would end up in the hospital over and over again. He loved us as a health system, very caring, nurturing care, and we got him home every time. But he was always afraid, and his wife was always afraid that he was going to die soon, and waiting for the next hospitalization. How many of you are waiting for your next hospitalization, excited? I can't wait to go to the hospital, especially the intensive care unit. And yet, as professionals in healthcare, that's what we put most of our energy behind, not health. So let me show you a story it was on the news, on the television, telling his story.
You're watching News Channel 5 on your side.
Skyrocketing healthcare costs affect all of us. Mercy Virtual Care Center has created a new program that focuses on patients whose care often costs the most. As News Channel 5's Kay Quinn reports, the objective is to keep them out of the doctor's office, out of the hospital, and healthy at home.
Hello.
Good morning, Jim. This is Megan.
At 74, Jim Hovelman is getting the kind of health care he never dreamed possible.
In the beginning, I was very skeptical. What are they going to do for me?
Jim, who suffers from chronic obstructive pulmonary disease, or COPD, lives outside Sullivan, Missouri, more than 70 miles from the nurses and physicians at Mercy's Virtual Care Center.
How are you feeling this morning?
Pretty good.
He's part of a program where patients communicate via iPad, removing barriers to care like location and transportation. Dr. Gavin Helton heads it up.
It's difficult for him to get out of the home, so we bring the care to him.
Each day, patients check their vital signs and answer questions about how they're feeling.
24/7, I can call that number and I've got somebody helping me.
We get to know his family, And we build a program specific to him that's ever evolving.
Video visits are scheduled 1 to 3 times a week.
Many times we know when something's happening with Jim before he even knows it.
Dr. Hilton called me on a Sunday night at 9:30, and he put me on a prednisone that night. And by next morning I was coming out of it again.
Sparing Jim an expensive hospital stay.
And I haven't regretted it, not 1 minute. And neither has my wife.
So what we did not do is take Jim out of his current care. His primary care physician continued. His pulmonologist continued to take care of him. What we did was create a team that was focused on him comprehensively to complement what others were doing, to integrate into what they were doing. But our objective was to respond proactively when we could. You heard Jim say, on a Sunday night, the doctor called him. If we would not have done that on Monday morning, he would have been in our intensive care unit, intubated again on a ventilator. So we proactively reversed it when it was easy to do. A very big change. We can't expect all of our doctors and practices to suddenly change and focus 24 hours a day. But with virtual care and technology, what we're able to do is our objective was to respond to every patient need within 5 minutes, just like we would do in a hospital. We would not allow Jim in a hospital to have his symptoms escalate without treating them, but we do it at home all the time. We also focused on this because Jim was a kind of person that was costing our system $100,000 a year or more from all of his hospitalizations. We needed money to invest in health. And by keeping Jim out of the hospital, which we successfully did for 22 months, he never saw our emergency room or our hospital again. And this is a letter from his family, his wife, when he died. But he died peacefully, at home, probably living a year and a half longer than he might have, with almost no cost. Because we simply brought care to him instead of waiting for him to come to care. And we could focus the resources, which I would challenge all of you to think, how do we act as a system? How do we leverage resources, because we can't do everything for everybody out of every site. It changes the world. I'll next show you a video that will go beyond and talk about the different types of programs and a bit of the history. I'll show you a picture of our 1,000-bed teaching hospital, but the types of approaches.
10 years ago, Mercy made a promise to get healthcare right. We reached out to Epic to create our state-of-the-art EHR. We invited our physicians to become innovators. And we began working towards the goal of a new care model with compassion at its core. With almost a decade running one of the world's largest tele-ICUs, we introduced the world's first virtual care center. It's powered by exceptional caregivers, proprietary algorithms, and Epic's ability to deliver patient data in real time. Our products and services are designed with feedback from health systems from around the country, including our own. They fill common gaps in the care continuum, and the results speak for themselves.
Your doctor should be in just a minute. We're going to get ahead of that pain.
In 2016 alone, patients admitted to our tele-ICU program had 35% lower mortality and 35% fewer days in the hospital. This eliminated more than 40,000 ICU days and even more in other units. Costs were reduced by millions of dollars. But most importantly, almost 1,000 men and women went home who weren't expected to.
We've run the sepsis protocol, and there are some red flags.
Mercy's telehospitalist program responds to calls in less than a minute and usually resolves issues in less than 10. Virtual support removes bottlenecks and keeps care plans moving forward. With implementation, hospitals enjoy reduced labor cost, physicians experience less turnover, and patients get home faster.
And when did the baby's fever begin?
Another success story is our comprehensive care management program. Working closely with Epic, our team of highly experienced nurses use customized applications to care for patients with chronic conditions. Representative clients have enjoyed strong results with 22% fewer sick days, a 20% reduction in medical spend, and a 15% drop in hospital admissions. The program quickly improves patient health and quickly reduces healthcare costs.
It looks like your blood pressure is a little bit high right now, so let's talk about how you're feeling.
In the US, almost 50% of healthcare dollars is invested in only 5% of the population. A new care model must better respond to the seriously ill and prevent unnecessary hospitalizations. To address this need, Mercy Virtual created the innovative Engagement at Home program. This highly personalized approach bridges gaps in the care continuum. Working directly with patients, navigators reduced costs by an impressive 30% and cut hospital admissions by half. By consistent management of complex conditions, this program gives patients more autonomy and minimizes disruption in their daily lives. Data drives innovation, and it also drives us. Our portfolio of services drops septic shock deaths by 60%, reduces false positive alerts for bedside nurses by 90%, and earns patient satisfaction scores of 98%. We're partnering with communities, employers, and healthcare systems across the country, ready to build a new model of care and get healthcare right. Ready to join us? Learn more at mercyvirtual.com/ready.
So we speak of this, the video was made in early 2017. One of the important things was saying we are on a journey. It first started in 2012. It takes time to build, but until 2014, we had loose programs scattered that weren't brought together, which is why we built the Virtual Care Center. We brought our 80 coworkers together. We built it to about 850 people who were just doing this to support this type of care, again, fully integrated into what else we do. It wasn't the ICU virtual team that reduced deaths. It was the ICU virtual care support linked with what we did in the hospital that did that. We also found that we could really leverage our resources. For instance, we lost many ICU nurses due to age and declining health who had brilliant brains, 25 years at the bedside, but they could no longer do bedside care. They became the majority of our virtual ICU nurses who could be working with a new nursing graduate at the bedside at 2 o'clock in the morning and helping her overcome issues she had never seen before. It'll enable them to work longer. We took our hospitalist, our doctors in the hospital, and you know, some hospitals can be really busy at one point and other times they're not as busy. And by linking our hospitalists together, we distributed work across them. And all of a sudden, we could respond much faster than we used to. But we had to get people thinking in a different way. What do you have in front of you? It's a busy slide, but there are several important points about it. The biggest one is it's a systems approach. We think of individual programs, and in healthcare, the way I was trained was I learned a certain part of my medicine from a mentor in the Department of Medicine, cardiology. And then the surgeon taught me something else in the way the surgeon did it. And everybody taught something different, and they all had their own world. And that works fine in our old health system, our old sickness system. But what we had to do with this is create programs that were intuitive, they were seamless, they were modular, because when a person left the intensive care unit, they went to the floor. We couldn't afford to change their care. It had to be a continuum. And went from the hospital, they might go to a nursing facility or a home. We had to have the same seamless care. So we made sure all the programs would work together that way, and whether a doctor or a nurse, a patient, a family member, they all had the same experience every time, which means you invest in infrastructure. You do, the group before me I couldn't understand, but design teams that will build programs that work the same way. And they have to work at a person's level who's not a healthcare professional. Very different from us as healthcare professionals. But at the end of the day also, very importantly here, the programs had to be combined into a sustainable business model. So we did analysis up front of what each of the programs and changes we are looking at introducing could do for the budget of the organization. And we combined them in such a way that would be unique to the situation to assure that we were generating the value that could allow it to be sustainable. So I'm going to go into a little bit of detail about key things that I've learned over the last 30 years about making a program successful. Keeping this as a background, a sustainable program. So first, again, a portfolio of solutions. What we're really doing, it's not about the solutions themselves. It's about breaking healthcare into health and care, as many of you talk about now. I grew up in a sickness care system. I was proud to be a doctor who could take care of very sick people. And we need to get better at sickness care. As I said, the ICU or the hospital for sepsis or whatever. But we need to put more and more of our focus on health so that especially the younger people here can look at a different future than what we've delivered in the past. We need to fill the gaps in care. We need to open our eyes and say, why do we have the gaps and can we fill them? I learned early, it's so important to identify your champions. You do this with doctors, with nurses, with people, not to them. You find where you have somebody with a passion who can do this and drive it, because there's always lots of resistance to change. Begin with large problems, in my experience, because small problems don't get recognized. Tackle large problems, whether it's the ICU, it's changing how surgery is done, it's changing the assessment of surgery. Around the world in Western medicine, 30 to 50% of surgery should not be done that's being done today. And I can tell many stories about that, and that's not United States alone, it's everywhere. When you re-engineer and look at this, it is not about clinicians working in isolation. It's not about IT, finance, or operations, or public relations. It's a systems approach, and if we don't take a systems approach, every time I've left a key stakeholder out, the program will eventually fail. We can't take care of the entire population all at once. I was asked last night, why don't we focus more on health instead of sickness? And part of the reason is we're not spending money on health today. So when you go to look for money to do something, it's hard to find. But if we can save thousands of deaths and thousands of hospitalizations, we can reallocate that money working with our government officials and others to say there's a smarter way to do this. And it's a segment at a time. The portfolio we talked about, I think of it in terms of mass customization. If it's modular, we can look at applying a specific plan to what any individual may need. And again, we have to make it cash flow. I look forward to the world in which I and every one of you have a single health and care plan that's ours. Mine currently is at Mayo Clinic. It's at the University of Minnesota. It's at Mercy. It's in a couple different doctors' offices, and none of them talk to each other. And they all make their own plan, and I can't see 4 out of 5 of them. They won't let me see my own plan. We need single plan that's specific to what you need, which is different from what you may need, and to build it around people and what's important. We have to simultaneously improve health through funding it with mitigation of the advancement of disease. Both at once. One you can think of as more of a consumer approach, one as more of a patient approach. But together, they can work to come up with a solution. And it's a systems analysis approach. It can't be done as any small group trying to think they will fix it. Health and care is all of us. At the end of the day, we need seamless, frictionless care and health experience. And I know in the Netherlands, like the US, we don't have that today. When you're trying to find who should you go to even for my condition or preventing a condition, it's difficult. You try to see a doctor, and it may take how long? Weeks, sometimes months, and then you may show up at the wrong doctor. We can overcome that with machine learning, artificial intelligence, virtual care, et cetera. And others, Dr. Ullman this morning talked about the Mayo experience and how a consultation virtually takes half the time and actually gives better results. But also by seeing the person when they need to be seen versus 2 months later, it may only be 10% of the amount of work that it would have been. We can do it very differently. I would also encourage each of you in your organizations to pre-write your story. Don't just start with something cool and say we can do mobile health. Start with an end that you would like to see the world press talking about what was done in the Netherlands. How did we transform our system? How do we put our Dutch people at the center of what we do every day? My same young man fighting. I've also learned, and this is not something that's bad, change is difficult and change is frightening, and we have to address what's in it for each individual. We begin with the patient. But if a group of doctors feel that they're no longer going to have their job, or a hospital administrator, his budget's going to be cut or her budget's going to be cut, that raises concerns. So in pre-writing our narrative, think about how to bring more value back as a society. At Mercy, and in my current role as Chief Operating Officer of another large system, the role I'm looking at right now, the story we're writing, is we are going to take care of twice the number of people we used to. We are not going to build any new hospital beds. We're going to reduce our hospital beds. We're going to improve the health status of the people we serve, giving them half of the care that we do today. Because we're not going to allow their sickness to advance to need more care. And we're going to build it around them and their needs. If we do that, what we want to do is become the most trusted and the most loved system there is. Because when you are at risk of dying, or you're thinking about your grandmother or your future, to have trust and love with expertise is something that makes all of us feel good. But think about what every stakeholder may be needing to do to change and be a part of the solution. I'm going to skip this. I'm going to close, and then I have a series of slides I can use in questions and answers. But I want to close with this again. Here are a few faces from Mercy. They are among 750,000 patients that we took care of through virtual care in 2018. 750,000. It cost us $54 million to build our virtual care hospital. It cost us $1 billion to build a 250-bed regular hospital. The regular hospital saw less than 100,000 patients for $1 billion of cost to our system. Virtual care saw over 7 times the number of patients, and I would argue had a bigger impact. But we worked with that other hospital. But how should we do it differently? And I want to call your attention to the man in the middle. His name was Mike. And Mike was a person who had both advanced emphysema and heart failure. And Mike was taken care of many times, including 3 helicopter rides for air evacuation to our intensive care unit. Mike had previously been a Vietnam veteran, and he told us, I never got to ride in a helicopter as a soldier. But Mercy has given me 3 rides, and I would never want to have another one. 4.5 years later, Mike has just not had helicopter rides. He's never been back in our hospital. He's never been back in our emergency room. And we've stabilized him because we bring care to him just in time. And his question, he said, to ask all audiences that are interested in changing health is, if this can be done, what took you so long to actually do it? I loved Mercy before, but this is totally different. So I want to also congratulate all of you for the intelligence and the passion that you put into what you do to bring health and care and technology where it is today. But I also want to have you leave here challenged to work with others, think much bigger, more comprehensively about how we can do it differently. And must we do it differently? So thank you. Again, I have some additional slides about different programs, sepsis, ICU, ambulatory, et cetera, but I want to leave a little bit of time for some questions, and we can use those if it makes any sense. Thank you again.
Okay, thank you very much. Thank you very much, first of all, for all your passion and the way you say we have to rethink about our system. Is it the system ourselves who is changing, or is the patients or the clients asking us to have another system?
I think it's both. Many of us don't know to ask for, I'd really like to have an iPhone 20 years ago, because I think an iPhone would be really cool. It might change my life. So many times as consumers, we don't know what's possible. So part of what we've done, and I would challenge you to do, instead of making just sustaining innovation, to look at transformative innovation. Because transformative can change what people expect should be done. And then it's us too, because we're the ones who have to create it. We have to get out of our comfort zones. And I think most of us know our current health system doesn't serve us nearly as well as it can. So I think it's the entire ecosystem again.
My second question is, and then I go, of course, to the other questions. The business part, you say we save a lot of money. Up till now, many times we are paid by doing things and not by not doing things, or even not having to do anything. How do you, because you say we have to invest as well, how does it work in the USA?
Yeah. So in the USA, we were totally paid in our system by doing things. We got paid to do surgery. We did not get paid not to do surgery. So what we did is also, we went to the government, to Medicare, and we looked at, could you prepay us? If the government, if a politician has a budget of $1 billion, what we did is go and say, using that as an example, we will deliver better care, more satisfied people for $980 million. We will guarantee we'll save you $20 million, but you have to give us the money up front. That's oversimplifying, but it's a way to do it. Same thing with insurance companies. We're doing that in my current health system right now. We're working with our insurance companies to say, prepay us instead of paying us after we do something. Then we can say we can use those dollars, the money, to invest to keep Jim out of the hospital. At $1,000 a month is what it cost us to keep Jim out of the hospital. Every time Jim was in the hospital, it was $18,000. Right. So we have, it is, and every environment's unique. But I think every environment knows it's paying a certain amount of money. We have to create the shift from, don't pay me to do something to your body, pay the health system to deliver better health. It's 180 degrees different.
I look around. If there are some questions, remarks, I come to you.
Good evening, Two questions. The first is, what's the role of Epic in your hospital, in Mercy Virtual? And the second one is, could you take us in the future for, let's say, 15 years or so? How do you think...
Only 50?
I said 15.
Oh, 15, okay,
Yeah.
okay.
So I'm curious to hear your vision about this.
Sure. So first, Epic, or the role of electronic medical record. As a health system, Mercy used Epic. So we had it in every hospital, every clinic, et cetera, which helped us. As a virtual care hospital, we were building a layer on top of Epic because we also had hospitals we were serving that were on Cerner or Meditech or another system. The EMRs are a necessary evil. And I think they were built in the US to optimize billing and to minimize fraud, in my simple analysis as a doctor. They weren't built to coordinate care. So they are working on coordinating care right now, but they're all doing it somewhat independently still. So I believe there is an opportunity for a solution that's the personal health record, which I know there are people in the room who are working on that right now. The second is, what does the future look like? I believe 15 years in the future, we will have large advances in AI and machine learning. We were using that behind Mercy Virtual because the key was not waiting for Jim to tell us he was getting sick. It was knowing through a combination of factors that Jim was getting sick, which we could tell, for instance, if his sleep started to become unsettled, was one of the indicators. But maybe it would be because they're not on Facebook as much with their grandkids. Maybe it's because we see patterns that we'd never looked at before. We will be in a future where 80% of what's done by our healthcare is not through invading people's bodies. It will be remote and more real time. How many of you have a smart device on? How many of you are starting to get feedback into what, is it great information, knowledge today? No, but it's getting better fast. I can see if I'm in atrial fibrillation through my iWatch, right? There are hundreds of companies that are developing individual solutions. A key in success, here or elsewhere, is to make sure we're bringing them together into a common ecosystem. Otherwise, we're going to create more challenges and try to operationalize it.
I look around. If there are some other questions, I come to you.
It's an inspiring story, but I want to elaborate on the previous question. Do all your virtual care providers work in an Epic layer, or do they use different systems?
Our care providers, and I mentioned something else about our care providers. For instance, our intensive care doctors, we had over 60 intensive care doctors doing virtual care. But all but 3 were also still doing bedside care. Most of them did at least 75% bedside care, and then they'd come and do a shift or two of virtual care. Same as we started building with nurses. So the future also, I anticipate that virtual will disappear into the fabric of healthcare practice and health. And back to where they were working, our intensive care doctors, if they were taking care of a person in an Epic hospital, we did use Epic. We went down an Epic. But if it's a Cerner, we went down into Cerner. So we and it was still not as functional as it should be, but we started creating the interface of saying we had to be EMR agnostic. But having the EMR is also critical. If you do not have an EMR, I've started several virtual programs much earlier in my life before the EMR really even existed. And we created our own miniature EMR, very focused on the condition of the patient that was going to drive the key things that we needed to do. We couldn't be as holistic, but we could still create major change.
One more question over here.
Yeah, Mr. Moore, thank you for your presentation. I was just wondering how digitally mature do patients have to be in order for the Mercy solution to actually work?
So how digitally mature do we need to be? The answer is almost not at all. It depends on your technology, though. So as I mentioned in the beginning, we need to think about a non-professional as the patient, often the person of highest needs. So we built technology, had our programmers take the iPad, put a single button on the iPad, and when we called the iPad, if they could touch the button, they were done. That's all they needed to do, all right? And that was important. Now, the other thing we did was we wanted to pull people into mobile and digital. So it was, do we create the ability for grandma, who's our patient, to FaceTime with her granddaughter, who could also be technical support for us? So it ranges. The easier you make the solution, the more intuitive, the better, especially for us doctors. You know, I wanted something very easy. And we will be moving more and more to passive. So all the things we did to grandma to monitor at home, Bluetooth, wireless, went right into her device, to us, to our analytics, and she didn't have to do anything. And we need to have the AI engines running, because another thing I saw experience, some could relate, you could do something called pulse oximetry to measure the oxygen in somebody's blood, which is important for a lot of conditions. The pulse oximeter will give you a reading every second. And somebody thought that it would be good for the doctor to be able to see the pulse oximetry of a patient overnight. And so in the morning, before, this wasn't systems like level thinking, the technology person alone says, this is cool, I can send a signal to the doctor. On one patient overnight, there were 40,000 readings. I would argue the doctor wasn't quite happy with that. So again, there are a lot of technology people, operations, human factors. This is a systems approach that's a journey. 15 years from now, we will all still be gainfully employed as we continue to evolve to person-centric health and patient-centric care.
One more, last question before you go. This is about a lot of things you can measure, like heart rate, like blood pressure. Like we see in all our societies a lot of mental problems, or people just feeling not completely well. And when we measure something, we hardly find something which how do we treat that? And is it also possible in this?
Getting away from traditional medicine. I was classically trained in medicine at Johns Hopkins, a very scientific place, and it was all about the science and that, right? What we have found out, as many of you know, is that of all what we do in health, 50% is determined by your zip code, where you live, the social determinants of health. 30% by your genetic code, and maybe 20% by what we do as doctors and nurses historically in hospitals. So it's a key focus. You hit something strong. In our care of our most complex patients, we assumed that they had to have mental conditions, stress, anxiety, et cetera. And that's going to be one of the strongest things. We created communities so people could talk to people. We found it wasn't so much what the doctor did, but for somebody very complex, it might be to have a person talk to them every day. Mental health, as many of you may know, the tools in mental health are amazing, from just reading facial expression, seeing changes in blood perfusion. To be able to, the machines will be able to give us tools that we never imagined possible to understand a person much more holistically. But as we do that also, this more complete, at the end last night too, somebody asked about all this data and how are we going to use it, and the hundreds of companies and everything. And one of the things that I remembered at Mercy Virtual, we had the Boeing Airlines executive team come in because we were taking care of a lot of Boeing employees. They wanted to come in and see our virtual care center. And one of the executives commented, what you're doing in virtual care is what we did in the cockpit many years ago. We changed flying so that millions of data points were coming into the captain, to the crew, all the time. In the old days, too many data points came in, and now the only data that comes in is the data they need to give as perfect of a flight as possible. And that's what we have to do in health.
I will say Captain Randall Moore, thank you very, very much for being with us here. Share all your knowledge and experience. Thank you very much.